Allergic rhinitis cannot be cured. The goal of the therapy is to reduce symptoms and improve the patient's quality of life. Starting off with a non-pharmacological treatment, which might help in retarding progression of the disease as well as to decrease the medication use. The first advice we give the patient is to avoid any known allergen. For example, environmental control measurements. For example, removal of the pads, the use of air filtration systems such as the HEPA filters, bed covers, and acaricides, which are chemical agents that kill dust mites, in allergic rhinitis patients who have identified allergens that correlate with their clinical symptoms. In addition, natural oils can also be used. Those who provided efficacy are the clove, rosemary, eucalyptus oil, witch hazel, lavender, tea tree oil, and to a lesser extent the lemon and peppermint oil. Patients whose allergies are triggered by an air pollutant should be aware of the Air Quality Index, AQI, which is a measure of the 5 major air pollutants per 24 hours. So they look on the Google when is this AQI low for this specific allergens, and accordingly they plan their outdoor activities. Pollen counts are highest in the early morning and in the evening, and lowest after a rainstorm clears the air. Avoiding outdoor activities when pollen counts are high and closing the house and car windows reduce the pollen exposure. Moving on, there is the nasal wetting agents that include saline, propylene, and polyethylene glycol sprays or gels, or even nasal irrigation with worm saline, whether it's isotonic or hypertonic solution, may relieve nasal mucosal irritation and dryness, thus decreasing nasal stiffness, rhinorrhea, and sneezing. This process also aids in the removal of dried, encrusted, or thick mucus from the nose. The main side effects of these nasal saline sprays is the mild stinging or burning, which has been noted with saline irrigation. One of the most famous example is the Physiomer, which have adult formulations for those that are 6 years and older. It has those for 10 years and older, 2 years and older, and it have different type as you're seeing in the picture. There is normal jet and stronger jet, as well as decongestant or even with essential oils such as the eucalyptus, and even there's a formulations for babies, which is used for those that are more than 2 years old. In the treatment of the nasal symptoms, or which means in case of stuffy nose, it's used 4 to 6 times a day. In daily use, whether it's in hygiene or prevention, it's used 1 to 2 times a day. Now, how do we use this nasal saline? Before use, of course, we want to check if it works properly. And then we need to tilt our head to one side, gently insert the nozzle in the upper nostril and press the nozzle once firmly for 1 to 2 seconds, and then let the solution act for a few seconds. Repeat with the other nostril and then blow your nose. And when you finish, make sure to remove the cap, or the nozzle, and wash the nozzle with hot water after each use, and then dry properly, and then put it back in the bottle, as you're seeing in these pictures. There is no specific treatment that is the ideal treatment to start off in patients with allergic rhinitis. However, intranasal steroids have shown superiority in working on all of the nasal symptoms as well as the ocular symptoms. In addition, they reduce bronchial hyperactivity, which means that they are effective in patients having asthma. And they are usually used for those that the quality of life is affected, which means in moderate to severe allergic rhinitis. And how do they work? They have anti-inflammatory action, and this anti-inflammatory action decreases the inflammatory mediators such as the neutrophils, the eosinophils, which contribute to allergic rhinitis. Now, which steroid is better than the others? All of the steroids are equally effective, and they include triamcinolone, budesonide, flunisolide, fluticasone, mometazone, and cyclophosphamide. How are they used? Usually it's used 1 spray per nostril for small aged population and 2 sprays per nostril for older ages. They take few hours to few days to work, and the efficacy would be reached after 1 week of therapy at the most. So if there is no evidence of efficacy, or if the symptoms are still presented, then the treatment is considered ineffective, and switching to another treatment or adding another treatment may be considered. And usually, if the patient was taking 2 sprays of this intranasal steroids, we usually de-escalate to 1 spray once the symptoms start to improve. Now, what are the side effects of these intranasal steroids? The most common side effects of intranasal steroids are a result of local irritation, dryness, burning, stinging, and epistaxis, which is bleeding from the nose. Intranasal steroid might cause sore throat, also known as pharyngitis or oral thrush, if there is wrong head positioning. So you can either prevent it by proper intranasal steroid positioning and administration, or you can prevent it by applying saline before the steroid as well. Epistaxis, which is nosebleed, can also be minimized with proper intranasal steroid positioning and administration, generally pointed away from the septum within each side of the nose. I'm going to display now a video that will help you know how to use this intranasal formulation.
You must prime your nasal spray before use, whether it's a new pump or you haven't used it in a while. Priming ensures that your spray is ready to deliver the correct dose of steroid each time you use it. To prime your nasal spray, hold it as shown, remove the cap and point it away from you. Give your spray a few pumps until you see a fine mist. Now it's ready to use. The first step is to blow your nose. Remove the cap and give your spray a shake. You want to tilt your head slightly forwards, and starting with your left nostril, use your left hand to gently open the left nostril, and use your right hand to direct the tip of the spray bottle out and slightly up. Imagine you're aiming the end of the spray towards the outer part of your left eye. It's essential that you use the opposite hand to the nostril being sprayed, because this helps ensure that the medication is directed to the correct part of your nose. If you experience the sensation of the medication dripping out of the nose, a gentle sniff is all that's needed. Big snorts are a no-no. After spraying, you may be tempted to take a deep sniff. This is a common downfall. Doing this sucks the medication away from the nasal lining and collects it at the back of your throat. It's common for patients who do this to say they can taste the spray. Ultimately, if you can taste it, the medication is getting to the wrong place, and it isn't doing much for your nasal passage. Small sniffs, of course, are okay, as we've discussed, and can prevent your medication from dripping out of your nose.
The second thing that we can use in allergic rhinitis are the antihistamines. The advantages of the intranasal antihistamines include the rapid onset of action, which is usually 15 to 30 minutes, which is much faster than the oral antihistamine, which usually take about 150 minutes. In addition, they have a more rapid onset of action than the intranasal steroids. And also the last advantage is that they can be taken as once daily dosing. Oral antihistamine work on the mild symptoms more and not much effect on congestion. The use of first-generation agents is limited by the side effect of sedation and mucosal dryness. Sedating antihistamines have a quick onset of action but also have a shorter duration of action and require multiple daily doses. The first generation include diphenhydramine, chlorpheniramine, and hydroxyzine. The second generation antihistamines include fexofenadine, cetirizine, levocetirizine, loratadine, and desloratadine. The WHO now recommend the non-sedating second generation antihistamines as the first-line therapy on the basis of their efficacy and safety profile, quick onset of action, long duration, which allows the once-daily dosing. Oral antihistamine once, however, some doctor, if it's very severe, they can go with twice or BID dosing if severe. The histamines are all equally effective, however, cetirizine was found to be more sedating, and we might have individual differences between different antihistamines as well. Loratadine does not cause much sedation and can be taken anytime during the day, and it works usually within 1 hour and it peaks within 2 to 3 hours. Now for the intranasal antihistamines, we have the olopatadine and the azilastine, and it's usually taken 1 to 2 sprays per day or even twice daily. The most common adverse effect related to the intranasal antihistamines are bitter taste, epistaxis, headache, somnolence, and nasal burning. Another class is the decongestant. Now, if we're taking it intranasally, then we take 2 sprays twice daily. However, if we're taking it orally, then we can take it with or without fluid, usually every 4 to 6 hours. Now, what are the decongestants? Oxymetazoline, phenylephrine, pseudoephedrine. Now, if we have a patient that the primary complaint is congestion, do we take intranasal decongestant or an oral decongestant? Well, of course, in this case, we take an oral decongestant because the allergy will last for several weeks, and the intranasal decongestant, as you all might know, that they should not be taken more than 5 days. And also a question here is, why don't we use intranasal decongestant for more than 5 days? It's because of the development of rhinitis medicamentosa, which is a rebound nasal congestion from the overuse of the intranasal oxymetazoline or any other decongestant, which is a big concern. Adding an oral decongestant to a second-generation antihistamine increases the side effects of insomnia, headache, dry mouth, and nervousness, while oral antihistamines and intranasal steroids are common selection for primary monotherapy. Their combination does not offer much of a clinical benefit. In addition, oral decongestant might cause tolerance. The last class is the leukotrienes. They are the least effective. However, there may be a subset of patients who have allergic rhinitis and asthma who may benefit from this medication, because we said that leukotrienes are inflammatory mediators that are shared between allergic rhinitis and asthma. Also, leukotrienes cannot be used as an additive in allergic rhinitis patient. Montelukast is generally well tolerated, is not associated with drowsiness, and it's the only one that's FDA approved for allergic rhinitis. Now, prophylaxis, we can give oral antihistamines as prophylaxis before 3 hours from allergen exposure. As well, we can give intranasal steroids 2 days before the season, during it, and 2 days after. Now, how do we start treating? Usually, we start monotherapy, and then if it's ineffective, then we can give combination therapy. When initial therapy with an intranasal steroid does not lead to adequate control of allergic nasal symptoms, or the patient cannot tolerate the intranasal steroid, the practitioner may choose a combination therapy, of which is most effective additive to an intranasal steroid is an intranasal antihistamines. If nasal sprays are disliked or not tolerated, combination therapy of an oral antihistamine and decongestant is the next most effective pharmacotherapy for allergic rhinitis. Oral formulation have not shown better efficacy than the intranasal formulation. Now, this table shows how are we going to start with the treatment. Now, if the nasal congestion is the dominant complaint, we need to give an intranasal steroids or an oral decongestant. Now, if the main complaint is intermittent sneezing, nasal itching, and rhinorrhea, then we can start with oral antihistamine or intranasal antihistamine. And of course, intranasal antihistamine being the preferred route. For mild symptoms, usually we start with an oral antihistamines, and if there is a poor control, we can go to intranasal steroids or intranasal antihistamine, or we can directly start with the intranasals. Now, if there is a moderate to severe symptoms, we can start with either intranasal steroids or intranasal antihistamine. And if someone prefers a complementary medicine, then he can seek acupuncture. Now, this explains what happened upon failure of the first therapy. So if we're taking oral antihistamine monotherapy and there is failure of the treatment, then we can switch the patient to intranasal steroids or to intranasal antihistamines. However, we don't add on the intranasals. No, we only switch to intranasal. And if there is inadequate control of the symptoms and the patient doesn't want to take any intranasal formulation, then we can add an oral decongestant. However, we need to warn him about the increased side effects of headache, dry mouth, hypertension, and nervousness. Now, if someone was taking intranasal steroids monotherapy and there is inadequate control of the symptoms, then we can add the best combination, which is the intranasal antihistamine. Or even if there is much congestion, we can add the intranasal decongestant, which is oxymetazoline. However, we only take it for 3 days or less, and as we said, we do not give it more than 5 days because of the rebound congestion that might happen. And of course, we do not add the orals because oral and intranasals are not the best combination. Now, if someone is taking intranasal antihistamine, then we can add intranasal steroid upon failure of treatment. And also, the patients might undergo allergy testing and receive immunotherapy if it's a positive allergy testing. What is immunotherapy? Immunotherapy is a subcutaneous injection that involves a small amount of the allergen, because of an evidence that giving a small amount of the allergen itself might decrease this sensitivity toward it, or this inflammatory response against it. The last thing I want to talk about is the The last thing I want to talk about are the special population. For example, the pregnant woman. The pregnant woman usually we start with non-pharmacological treatment, and also we can go for a cromolyn nasal solution, which is usually also one spray every 4 to 6 hours. And also we can go to oral antihistamines such as the cetirizine or loratadine, and if ineffective, then we can go to an intranasal steroid, which are the fluticasone and mometazone, and we keep away from the triamcinolone as it's not recommended for pregnant women. And for the child, usually we go for intranasal steroids such as fluticasone and mometazone. That was all about allergic rhinitis. Thanks for watching.